everybody. It's John Nosta here. I have got a good friend with me today, Ben Wang, who's the CEO of Profusa, a company that I've known about for a long time. And we're going to chat it up a little bit, Ben. I've got no real agenda here, but let's kind of start it out with you. I love your background. It parallels mine in kind of a fun way. So tell me the Ben Hwang story. 30 seconds. Maybe take a minute.
Yeah, let's take a minute. Hey, thanks, John. It's a lot of fun to see you. Appreciate you doing this. Listen, my background is actually quite eclectic. I love science, and I fell in love with science actually later in life. I'm an immigrant from Taiwan, came to the country when I was 9, got really lucky early on, did a variety of different fun, interesting jobs, one of which was with the LA Dodgers. I was a bat boy for the Dodgers, 17, 18 years old, dropped out of school because of work. And one summer, when I realized that I can't be a Batman anymore because there's only one of those guys and he lives in Gotham City, I went knocking on doors, trying to find a summer job. And the community college I was at was about 2 blocks away from Caltech campus. And I was very fortunate while knocking on the doors of the Caltech campus, I got a summer fellowship in the lab of Lee Hood. And that really started my love of science.
Just take a step back, okay? I mean, just tell us about Lee Hood. I mean, you kind of went over that quickly. So you stumble. Okay, so here's the interesting thing, Ben. I stumbled into Eugene Brunwell's laboratory at the Brigham and Women's Hospital, and stumbled in. So tell us a minute about Lee Hood, because he really is, is it integrated medicine, integral medicine? What is his thing?
Yeah, so it's systems biology, right? He was the first to coin systems biology. So this is semi-funny. I knew nothing about science, how science works, the ecosystem of science. I just wanted a job. And I figure a job in a laboratory is better than a job, working in a restaurant or at a clothing store. And I went and knocking on doors looking for a job, had no success. I went to the biology office and the lady gave me a catalog and said, the best way to find a job is look through the work our professors are working on and find one that's of interest to you. And then specifically asked a professor for a job in his or her lab. And I went back, and of course, I could read the words, but I had no idea what the words mean in terms of the description of the science, right? And I thought, well, I'm kind of stuck. And I ended up, this is how idiotic I was back then, or ignorant I was back then. I thought to myself, listen, you know nothing about biology, you know nothing about science, you're a community college kid. Had 1 year of classes under your belt. You can't make any contribution. You're basically asking for a job. And I thought, if I joined a lab with 4 people, I'd stick out like a sore thumb. So I should find a lab with as many people as possible. In that way, I could kind of hide, and maybe they'll just take me in, empty trash cans or whatever. So the largest lab at the time on Caltech campus was Lee Hood's lab. What I didn't make the connection was the reason he had a huge lab was he was so famous and so well funded that everybody wanted a job in Lee Hood's lab. But anyways, I got lucky. I knocked on the door, got shuttled to his lab manager, and I said I was a PCC student down the street, love to wash test tubes or just be around this environment. Wow. And I was fortunate enough for the lab manager to say, yeah, well, sure, we have this fellowship. Maybe you could apply for it and get in. Once I applied for that fellowship, it was a couple of page application. Of course, it's completely blank because I had no publications, no classes to speak of. But I think it was because I had the gumption to knock on the door. They took me on. And from that moment forward, I realized the power of what science can mean to the world. This was right at the time when Lee's lab or Dr. Hood's lab just published the automated DNA sequencing, the capillary sequencing methodology that turned into Applied Biosystems as a company, and it made solving the genome from an impossibility to a probable outcome. It went from trillions of dollars in hundreds of years to solve 3 billion bases. really down to they were able to solve it within years and, you know, $25 million or so. And that really made such an impression on me that the right technology at the right time really could change in a very fundamental way. You know, DNA sequencing is the basis of all of our medical knowledge today. And that was a really, really lucky moment for me to knock on that door and for that door to be open.
And we, you know, the interesting thing about DNA sequencing is what we saw is not only an exponential change in utility, but an inverse exponential change in cost. How that first DNA, you know, that was just such a ridiculous amount of money. Now I would argue that we're probably going to do it for free because it's just, yeah. So now there's an academic side here too, right?
Yeah. Well,
so these great credentials, I'm trying to pick them apart a little bit.
Yeah. So listen, as a high school dropout, GED guy, I had to take the SAT over again. I was 23-year-old freshman. And during my summer, Lee was and is an incredibly gracious gentleman, no air about him whatsoever. And toward the end of the summer, and that fellowship was pretty prestigious. I don't know why they picked me, to be honest with you. The 9 other folks who were there are MD, PhD students at Ivy League schools, et cetera. I was the only community college guy who was a freshman. And at the end, Lee asked me, said, "What are your plans?" And I didn't really have much other than I told him this really got me interested in sciences this summer, and I find it fascinating. And he suggested that I should go to a school outside of California. He suggested either Hopkins or maybe staying at Caltech. I had wanted to get out of the state, experience a little bit of what the rest of the country had to offer. And so he made a call, made an introduction, and I ended up being at Johns Hopkins, where I finished my master's and PhD in biological sciences from Johns Hopkins. And it was really from knocking on that door. And it was such a great experience. I think it was one of those pivotal moments in my life. And it stuck with me, right, John? To your point, a technology, even though it sounds simple, really could change the world for the better with outcomes and consequences that I think Lee at the time probably couldn't even fathom.
I mean, you know, you could lean on serendipity. You can say you were at the right place at the right time. You know, I think that it's a bit when opportunity meets desire or preparation. So, okay, so I want to get into Profusa because I want to talk about biochemistry, and I want to use as many big words as I possibly can. Okay. So you can't use any big words. I'll use the big words. So how did Profusa come to be? And I really want to kind of dig in that a little bit.
Yeah. So about 15 years ago, I had gone on with my career in large companies and through consulting, et cetera, and had a pretty gratifying career.
Yeah.
And about 15 years ago, I ran across a former colleague of mine at McKinsey, and she had this technical idea, a startup that she wanted to start, which is with a couple of partners, the whole concept of wearables and real-time information that changed our lives. At the time, if you remember, this is when Google was on the ascend, when Amazon was starting to be very, very successful. And there was a lot of notion that if you have real-time information around you, you could make choices and decisions that could change your lives for the better. And we were living it, right? 15 years ago, we were starting to live it with a smartphone, et cetera. And the notion is always, if you could do that for parts of your life, that's more transactional. Can you really apply that same level of thinking that if you have real-time, accurate and usable information, can that change healthcare and how you live your life for the better in terms of your health? And that was the idea. I think the concept existed with Fitbit, with counting steps, power of computation, kind of figure out the science after you gather all of this data.
But what was your first target? So, okay, so we've got heart rate and all that mumbo, the easy stuff, right? How did you get, I don't even want to say it yet. I want you to say it. How did you get to like those other physiologic targets that to me are the big news here? I think a lot of people are missing.
Yeah, so the first target really was glucose. It was an easy one to actually think. And the idea was, if you could make a glucose sensor for continuous monitoring diabetes management that's just as accurate but much easier to use and a lot lower cost, like a Fitbit, and measure glucose, then that was kind of the game-changing winner. I think we in the beginning, Profusa's mandate has always been, if it's just an incremental improvement, then it's not worth doing, because there are tons of people out there that are trying to coat the needle or make the chemistry last a little longer and trying to get the sensor life from 10 to 12 days to 14 days and celebrate that as a win. A lot of smart people doing that. We don't have to do that. If we could actually do it where there's a 3-month, 6-month duration sensor.
How did you get to the subcutaneous space, and how did you get to using those little filaments? I've been calling them nanofibers.
Right.
So, like,
yeah, John.
Then you got like, the other big guns breathing down your back, right? With conventional continuous blood glucose monitoring that's using functionally, I guess, a needle into the subcutaneous space.
That's right.
Dissect that a little bit so I can understand that.
Yeah. So the big insight there, John, was if we want a sensor to last a long time, then you have to solve a fundamental problem. And the fundamental problem for these needles lasting only 10 days, 12 days, 14 days is this phenomenon called a foreign body response. And the foreign body response really is an offshoot immunological response, which is your body's exquisitely good at determining what belongs inside versus not. These sensors that are needle-based, you change them out every 10 to 14 days, not because the sensors stop working. It's because your body starts to encapsulate.
Does anybody know that? I mean, as a diabetic patient or someone with metabolic syndrome, where I'm looking at the utility of CGM, the reason I have to change it is because my body rejects it, not because it wears out, right?
That's exactly right. So the user may not know it, but it was common knowledge within the industry. Within the industry, overcoming that foreign body response at the time was an impossibility, or at least it's a likely outcome. But there were so many shots on goals on do that, because if you solve that foreign body response problem, then the duration of the sensor and what you could put inside the body becomes not limited by the biology, but becomes limited by the
So what was the aha moment? How did you go to that? I guess I'm calling it a needle, a fiber, something that went through the epidermis, right? That made its way out. That you guys changed the game here. And again, I just want to underscore that I think this is fundamentally important. That is the big buried lead that people aren't seeing. So take me. So who am I? I'm Abbott, let's say, right? And I got this big clunky thing on my arm with this needle that goes into the interstitial space, if that's the right spot.
Yep. Right.
But it has an immunological reaction. My body rejects. I got to change it all the time. Okay, so where do we go from there?
Right. So if you could solve that, then you have something.
Yeah.
And Profusa exists because we believe we've solved it. And here's the intellectual connection that we made.
Okay.
At that time, if you recall, stem cells were huge. And one of the aspirations of utilization of stem cell is to be able to grow organs so that you don't have to rely on an organ from a donor.
Yeah.
Right. And one of the approaches doing that was to strip all the cells away from an organ and then implant the scaffolding, what's remaining, the extracellular matrix, implant that and seed it with your own stem cells and then grow a new organ off of the scaffolding.
Right.
So imagine what problem they're trying to solve, right? What they're trying to solve is create a scaffolding that allows healthy tissue to grow throughout, high surface area, well vascularized. And our intellectual connection was, hey, can we take that same approach and create a sensor so that when you embed that sensor or inject that sensor under the skin, the body doesn't reject it. The body views it as normal, grows healthy tissue throughout, healthy vascularization throughout. Then all you need to do is use that scaffolding to deliver the sensing chemistry inside the body. The body doesn't reject it. The body not only doesn't reject it, grows healthy tissue within that scaffolding and creates good surface area and contact for your sensing chemistry. And then the only trick left is how do you get the sensor signal out? And so we went through that approach of, can you embed a sensor inside the body where there's no foreign body response or very little foreign body response, where tissue grows healthy throughout, and that three-dimensional extracellular matrix, if you will, was really our inspiration. And what we came to was, we saw this fundamental barrier. The fundamental barrier of being able to deliver a foreign agent inside the body where the body is, where it's benign and the body doesn't mind it being there. And then once that happened, without the biofouling and without the immunological response, then the entire world opens up to us, right? Then what you have is ability to deliver whatever sensing chemistry inside the body in the interstitial fluid space.
So I'm confused, Ben.
Mm-hmm.
You have the device in. How do you get the data out?
Yeah. So that was the next problem that we actually had to solve. The fundamental biological problem, once you solve that, how do you get the data out? And without a direct conduit, the easiest thing for us to do, which was not so easy, but we solved the problem, is through light. So it turns out that
take a breath here, because again, to me, this is fundamental, right?
Yeah.
That these sensors do not have to traverse the dermis. They don't have to stick out, right? And they live in the subdermal, the interstitial space, and then you use light, probably the most powerful source of data transmission that we know, right? Fiber optic cable.
Exactly.
And you use that in a self-contained, aseptic, data-rich environment. Am I getting it right?
That's perfect. I'm going to jot that down, John, because that sounds so good in terms of your wordsmithing on it. Mm-hmm. That's exactly right. We have the ability to actually throw this little sensing element, and it's almost a crime to call it a sensor, because most people, when you say a sensor, they think electronics, coils, signal out, signal in. For us, it's just a sensing element. It's a little thread.
How big is it? Tell me, you told me, like, how, I should say, how small is it?
Right. Fully hydrated inside the body, it's about 300 to 400 microns in diameter, about 3 millimeters long. When you dry it down or desiccate it for the injection, it's tiny. It fits inside the interior diameter of a 21 gauge needle.
Smaller than a human hair? Bigger than a human hair? I'm just trying to put it in perspective.
It's bigger than a human hair. It's probably the width of a few human hairs when you actually dry it down.
Okay.
It's very, very small.
So you so this gets administered. I didn't want to go there yet, but now I'm getting data using light.
Right.
That's wild. Tell me, keep going here. This is too good.
So that little fiber is injected into the skin, and the only thing that the little fiber has is the scaffolding material, which is a class of material called hydrogels. We all are familiar with it. It's the same class of material that contact lenses are made from, or wrinkle fillers, etc. Right? So it's soft and squishy, it's pliable. And embedded in that hydrogel is the sensing chemistry. It's the chemistry that binds to oxygen or glucose or lactate, whatever it is you actually want to measure. And that's it, full stop.
So,
no battery.
Is that an IP, Ben? What is your, so that's a key point here, is that this is a well-established substrate, but it has the IP to support the business side of this, right?
That's correct.
Are we still in glucose now?
Well,
I know, I'm trying to. We're like 20 minutes in, and I want to. Maybe we'll probably go over a half hour. This is just too rich. This is the Joe Rogan podcast of health technology. So we're gonna make this rich and interesting. So are we still glucosing here? Are we still there, or have we moved into other? And how did that even come to be? Because oxygen and lactate. I mean, it's just too cool. So
I'm describing a technology platform in terms of how it works.
But were you driven by glucose? Was glucose the target, or were you thinking of other You're thinking of other other levels to measure?
Our original business started thinking that we're going to do glucose.
Yeah.
What it evolved into was, because this is a platform, and we were talking about how data comes out.
Yeah.
Right. There's no electronics in that sensor. That sensing chemistry has a fluorophore attached to it, which is just a fancy way of saying it's a molecule that when you shine light on it, it emits light coming back. And And then if you have that sensor underneath, then you have a reader on the surface that shines light through the skin, illuminates the fluorophore on that sensor, it returns a signal back, and you have the reader that captures the light signal coming back, and then you could do it whatever you want with that data.
And it returns the signal back how frequently?
As frequently as you want. You could do it as frequently as 10 times a second, as infrequently as never, depending on how you actually, depending on the use case and what you actually
speed, part of the speed, because we know that with respect to rapid changes in glucose, ischemic changes happen very quickly. Even the rate of change of the ischemic change is important, right?
That's right. So one could argue that that's most important, right? That, you know, for glucose, a healthy individual, glucose excursion could still be large depending on what you're eating. What's important is if you're healthy and your glucose goes high, it comes down very rapidly.
We've looked at this, and back in my background, I was going to talk about my background in stumbling into Gene Bromwell's laboratory, becoming a student of cardiovascular pathophysiology. We looked at oxygen. We looked at myocardial oxygen consumption in a heart attack, and I don't think we really even begin to touch on the rate of change of glucose, DGDT. Right. I mean, the rate of change that we talk about postprandial glucose peaks, but those are in the blood, right?
That's correct.
You guys are doing something that's different here. And I think we're missing this point a little bit, right?
Yeah. So there.
Go ahead, give it to me, because this is so important.
So there are a couple of points that's actually important that I want to make here. From a technological side, right? We've overcome a couple of fundamental biological barriers over millions of years of evolution. And to be able to kind of overcome those things, we thought they were really important accomplishments. So our sensors function for months at a time instead of weeks because we've overcome the effects of this foreign body response. I think that's one. Two, because we actually are the way the architecture of the sensing platform works, if you replace the sensing chemistry, you can measure glucose for one sensor, you can measure oxygen for another sensor, you can measure lactate for another sensor. The things that you could actually measure inside the body in real time with high temporal resolution becomes a possibility and a likelihood. So that's a second thing. It's platform driven. So we started as a glucose company.
Yeah.
What we realized very quickly, speaking with vascular surgeons, speaking with interventional cardiologists, speaking with wound care specialists, what we found was measuring interstitial oxygen, measuring the oxygen level where the cells are bathed in this interstitial fluid and what the cells actually see, as opposed to measuring oxygen inside the blood vessel, like pulse oximetry, is a very, very important step forward for clinical utility and clinical application. Because you could have very healthy vascular system to have high degree of oxygen saturation within the vessel. But the cells never see it, right?
So let's say, I'm a guy with a diabetic foot. I've got really bad flow. But you look at my pulse oxygen, and my arterial pulse oxygen is 95 to 100, right?
That's exactly right.
Now, why are people missing this? I just, in the mainstream world, we talk about, first of all, everybody knows about the old days of blood oxygen, right? You have to, you stuck a needle in the radial artery, right? You used a glass syringe, you have to put it on ice, and then the resident or the respiratory therapist would run to the lab so you could get blood oxygen levels, PO2, PCO2, partial chemistries, a lot of stuff. But here you're doing something that is not just another PO2, partial pressure, right? You're looking at tissue levels, right?
That's absolutely right.
It's not, maybe we call it a game changer. To me, it's a more advanced level. It's the next level of understanding. Because if I have a FemPop procedure, right, a surgical procedure, and I'm reestablishing flow, it's really the oxygen level in the muscle that is critical. So, okay, so you started off with glucose. I get it. Was Libre, was Abbott, were those guys freestyle out there at that time? Was that sort of a competitive arena?
Not yet. At the time, the competitive arena in glucose was Dexcom, was a big player, and finger sticks, right? You traditionally you just do the finger sticks.
Pars, right?
It is. It's interesting that you actually raise this point about where you actually measure oxygen from. Listen, ultimately for us, it's difficult to explain sometimes, but we think one poor analogy maybe, or one analogy would be, you know, I live in California. Everybody's got these beautiful lawns and automated sprinkler systems. Some lawns do better than others. Pulse oximetry tells you whether there's water in the pipes in your automated sprinkler system. What we measure is much more important, we believe, or with clinical utility, which is the grass actually getting wet? Is the dirt actually getting the water? You could have water in the pipe, but if the water never gets to the dirt, it doesn't matter.
So basically what you're saying is there's blood levels, and I think that's where clinical medicine is, right? It's a venipuncture and a tube, and we're measuring the blood in the pipe when we need to measure the chemistry in the tissue, right? So we're moving from I guess what you'd say from blood to tissue, right?
Yeah. And listen, I think that's a natural progression, right? That the hundreds of years of clinical knowledge and clinical data that's been accumulated, I argue a lot of it is centered on blood, venous puncture, et cetera, because blood is easy to access.
Yep.
And there's knowledge you built on that bodily fluid. But when you have a better understanding of physiology and effect, what the physicians ultimately and the medical science is going to is, hey, what are the cells actually experiencing? What are the nutrients and the levels and the impact of what's available for the cellular at the cellular level, at the tissue level?
In our lab, when we needed to get oxygen levels in the myocardium, right, and we'd do epicardial, endocardial, we had to do a punch biopsy. Right. You know, in an animal model. It's crazy. So if I want to get, let's say I'm looking at a foot, right? And I want to get to diabetic foot, because I think that that's a very, very interesting connection, because we're going from glucose to diabetes, you know, to peripheral vascular abnormalities. So, you know, how do I measure tissue levels in the real world? I'm talking about, let's go, you know, we talk about oxygen levels.
Yeah. So right now, without Profusa's technology, it's very difficult to do on the tissue level. And there's still just proxy measurements. You image how well flow, you know, how much capillary and how much capillary glow there is in a particular area. You touch
push down on the skin.
Right.
That's the state of the art for capillary flow. It's nonsense.
Absolutely. It's pink, and you press it, and then it's white, and then see how quickly it becomes pink again. Surgeons, they're incredibly skilled, but the tools just aren't available to them. So that the only thing that they do right now is, look, the foot feels warm now after the surgical procedures, so we feel good about this.
What about Doppler, flow Doppler? Are you looking, that's just really arterial upstream flow, right? You're not looking at downstream microvascular flow, are you?
That's right. No, for Doppler, you're not, right? So these are all large vessel techniques, right?
Yeah.
Just to make sure that there's flow in the pipe.
Yeah.
Unfortunately, for many of these patients who are diabetic or have other comorbidities and other diseases, the pipe works fine, but the capillaries are dead, or the capillaries are hardened, and therefore gas exchange actually doesn't occur. And so you could have technical success in opening up the vessel and restoring flow to the extremities. The tissues themselves are not getting oxygen. You know, in that little environment, if I'm a cell, I'm just getting starved because gas exchange is not happening upstream. Where we measure, where Profusa's power of this technology is, when you solve the problems that we've solved, we're actually measuring then in real time what's happening in that interstitial fluid, the fluid that the cells actually experience. And then you can actually adjudication.
So number one, let me go back, because I want to get to this. This is real important. Number one, biologically inert, right? These are tiny little, you know, I call them nanofibers for lack of a better name. That's number one. Number two, it's not blood levels, it's tissue levels. And I just think that is such a fundamental difference. You know, the reason why clinicians don't know it is because that's not the way they were taught, right? We didn't, in medical school, we didn't learn about blood level. I'm sorry, about tissue levels. So you're actually using this sensor technology to interrogate a field, a muscular field, a foot, a peripheral leg. Like what is it we're looking at in this particular instance?
Yeah, so our sensor in this particular instance is looking at the microenvironment, that local environment of tissue perfusion. And just a fancy way of saying how much oxygen is actually in that field with the tissue.
I mean, tissue, again, it's not that's tissue perfusion,
it's
right?
Tissue, right.
I mean, Volvo owns safety. They own one friggin' word, Ben. You guys own tissue. Because right. that's where the Krebs cycle, the metabolic, the anaerobic, aerobic, it all takes place there. And I think this is really interesting. So without getting too technical, when there's revascularization, when there's a surgical intervention, when there's angioplasty, whatever intervention, a surgeon will take X number of these sensors, right? And how many? How does that work? How do you triangulate that? How do I get that kind of data?
So for the case of critical limb ischemia, for example, which is what we're talking about here, arteries blocked, the foot has tissue loss or wounds that will not heal. The anatomy of the foot, generally, there's this concept called angiozones, which is there are 3 branches of artery below the knee that delivers nominally oxygenation to 3 zones of the foot. And we really leave it up to the surgeon based on the surgeon's knowledge, and the surgeon has full control on what his or her therapeutic choices are inside the operating room and what they would like to see, right, as an end result of the map of the foot of how much oxygenation is returning to those tissue area. And the surgeon could choose to inject 1 or 2 or 3 sensors in the different parts of the foot. And then it becomes like a GPS, if you will, inside the operating room. That technically, they're working on creating flow, but clinically, they want to know if the tissue is going to get oxygen back. So they could have technical success without necessarily clinical success. And our sensor is the first to be able to tell them inside the OR, as you open up this vessel, you're getting the result that you want, which is that tissue is getting oxygenation, as opposed to, hey, I got flow now, and I hope that wound will heal.
So where do you stand on regulatory approval on this? So is this real world, or are we still in the lab?
It's real world. We received a CE approval for our oxygen sensor right before COVID. European Union has a change in their medical device regulation, so we have to update that. We expect to be able to generate product revenue off of our oxygen sensor in Europe come January or next year. These sensors have been deployed in hundreds of patients through a variety of clinical studies. That's how we're able to get our CE approval in Europe. We have surgeons that have used this that are really excited for this product to be on the market, that continue to work with us. So yeah, this is really beyond a laboratory exercise at this point.
Is your approval use-based for a procedure, or is it approved as an oxygen sensor? How broad is your approval here?
Our approval in Europe right now is for a specific use case of critical limb ischemia. So it's unfortunately a large population of folks who actually suffer from it. And we're excited to actually be able to provide this solution to make their lives a little better and make their physicians' lives a little better.
Where do you move this? If you're looking at critical limb ischemia now, where do you see this potentially going? Do you have a clinical development plan to expand this?
Yeah,
seems to know that the dollar market is huge here.
Right. So a couple of ways that this actually could go, right? So critical limb ischemia, ultimately, for this application for our sensor, and we're just talking about tissue oxygen, by the way, right? We're just talking
Oh, we haven't gotten to the other stuff.
And lactate and sodium and potassium, right? The same platform could do exactly the same thing, just with different analytes. With the tissue oxygen application, critical limb ischemia is one, but generally, that could be classified in the category of wound care. Why do wounds not heal? And most of the time, wounds don't heal either because of infection or because of vascular compromise, that the nutrients and oxygen is not getting to the wound site. So critical limb ischemia is under the umbrella of wound care. And you can imagine our ambition of expanding that to other areas of wound care, reconstructive surgery, burns, and any other kind of wound.
Boy, I'm thinking, reconstructive surgery with flaps. I mean, talk about all those flaps. I mean, there's the ischemic problem with flaps, getting the vascular supply there. It's almost like I wouldn't want to call it a circus, but it's really, it's weird to be able to monitor tissue oxygen levels here in flap procedures, dermatological procedures, reconstructive procedures, breast. I mean, so many things here is extraordinary.
And listen, we have aspirations, ambitions, and let me take the CEO Profusa hat off for a second and just talk about somebody who kind of just thinks about technology in a fun way. Listen, oxygen obviously is one of the most important molecules that sustains life. Nothing actually grows, at least in human body, right? Nothing grows without. And so much of what's important is in clinical science is how much oxygen is actually available for a variety of things. Tumor management, trying to shrink tumors. So many chemotherapy agents actually require oxygen around to create the free radicals and kill the cells. A bunch of surgical procedures during the ICU period is that wound site, is that organ site getting enough oxygenation so that the wound could heal or the organ could actually take on and on and on. And I think you can have a lot of fun thinking about what the applications are. I think for oxygenation, clearly it's important. I mean, we're just taking the first step out of the gate for a bunch of stuff that could actually happen, especially measuring.
You guys are the innovator here, right? I mean, you guys, this is your thing. Profusa, for my world, owns this.
We agree. Listen, the fun. One of the things that we talked about earlier, right, made me fall in love with science is it's really one of the fields where you build off the shoulders of giants. It's part of the scientific ethos and culture is you build off of what other accomplished. And we're incredibly grateful for the giants in the field and that have done so much to make all of our lives healthier, including my children and myself. And I think our ability to actually add to that is this area, is to take what is known in the blood vessel and take it into the tissue. And we think that actually is a really important barrier to overcome. That if you could do that at a form factor that's really easy to adopt, at a cost basis that's low, you could generate real-time data information on the tissue level, link it to all we know about the different biochemistries and what those numbers mean. We hope not only do we know this space, but that there's likely a body of clinical knowledge that we just don't even know today.
So there are a couple places I still want to go. Time is short. I want to talk about data. I want to talk about a lot of interesting things. I want to even touch base on the stock, on finances a little bit. But so we talked about glucose. I think glucose is a viable modality. It's measurable. It's proven. You've just got that in the bag. Tissue oxygen levels, really, really interesting to me. It's not the blood, it's the tissue. I mean, that's something is such an ownable idea. Tell me about lactate and how that came up and what are the sort of the physiologic implications? Of course, when we talk about oxygen, we talk about ischemia. When we talk about ischemia, we talk about blood lactate. When we talk about training as an athlete, we talk about blood lactate is extraordinary. So how does that fit into this picture?
Yeah. If you get a good real-time picture of your tissue, glucose, oxygen, lactate, that's the trifecta, right? In terms of metabolic.
I think that more than a trifecta, Ben, to me, in the back of my head, I've been thinking about this as a diagnostic triad, as a physiologic triad, everything from ischemic muscle dynamics in a diabetic foot to astronauts in space to Olympic athletes who are training. If I can get these three things tuned in really nice, I think it's even for longevity now. So where does lactate stand? Do you think lactate is coming? Is a potential?
Lactate is potentially coming. We've had good experience with lactate in the research.
Lactate's a pretty small molecule too, right?
That's right. And so we had good research activity on lactate through the funnel. I think we have short-term goals that we actually have to hit. And I would say lactate is probably a medium-term goal in terms of filling our funnel here. Listen, as a company, we are focused on helping as many people as we possibly can, as quickly as we possibly can. And oxygen, glucose, lactate, those are all things that actually we want to bring to the market as quickly as possible. You know, our part of our heritage also is we've received generous support from DARPA. And one of the things that DARPA really was cared about was lactate, trauma resuscitation, soldier health.
Ringer's lactated Ringer solution. I mean, it is as physiologic as sodium and chloride are in IV solutions, right?
That's exactly right. So it definitely is an important marker. We'll have our hands full. I think, you know, solving the fundamental biological barrier that has prevented a sensor like this from being developed in the past, overcoming the effects of the foreign body response, you know, bringing the cost down, having use cases or examples where you can actually have a sensor for months at a time that's easy on the user. I think once we get there, our ability to take that fundamental platform modality and put it in places beyond oxygen and glucose and lactate, et cetera, is a very exciting future for us.
Well, I think that we've struggled with measuring these critical compounds in situ, right? It's always been once removed. It's always been arterial or even venous, you know?
Right.
So this is really interesting to me. Now I want to push on this a little bit, because now you've got all this data. You are acquiring this data at the speed of light, right? At the speed of life. Where do we go now with all this data, particularly now that AI is sort of integral to processing this information?
Yeah, so we use AI and basic machine learning to make sure our sensor data is accurate. I think that's table stakes now. It's really difficult to talk about any kind of technology company with credibility if you say you're not using AI or you're not using some machine learning to just make your product better, right? And so obviously we embraced it. And I think we're really fortunate that we live in a world where these AI tools are really maturing alongside of us. What I will say, though, is, listen, beyond that table stakes, beyond the obvious, you know, I'm not the first, nor will I be the last med tech company to say we use AI. And I think that's going to be a stale headline pretty soon.
Sure.
But go beyond that. Let me be a little bolder and to say, you know, AI engines and AI tools, I think, are only as good as the information and data where the AI engine could process. And if we did a good enough job of explaining to folks what our technology actually does, we do two things. Our technology actually kind of opens up two doors on two different important areas. One is high temporal resolution of biochemistry information. It just didn't exist before. Biochemistry information in the past is once a year, once a month. You go to LabCorp, you go to get blood drawn, you have a static view. Excuse me. Now we actually have a continuous view where, to your point, DGDT or DLDT is really important. And I think from a clinical perspective, that body of information doesn't exist. With our data, it will exist.
Well, we're seeing this. We're seeing excuse me, the old days of getting your blood pressure measured every 6 months, right? To continuous blood pressure monitoring, to RR variability in an EKG. We're seeing that with the Apple Watch and all sorts of devices that are giving this data in real time. And I think that the biochemistries now are acquirable. And I think I want you to touch on accessibility and price here, because what you're doing is not expensive.
No.
So how does that fit into everybody's worried about money? You know, another innovation that costs $1,000 to get a blood tissue level,
right? So one of the beauties of actually our approach, and quite frankly, is one of our fundamental design tenets early on, is for us to really make an impact in this space. This technology needs to be accessible to folks.
Yeah.
And the accessibility, unfortunately, in the world that we live in today, is directly correlated to cost, right? And so for us, our technology, because our reader is decoupled from the sensing element, that reader could be, the electronics, the more expensive component could be reused over and over and over and over again. And that means that our fundamental cost, the structural cost of our technology platform, is just significantly lower than if you have to throw a sensor away and throw $40 away every time you actually change it.
Let's just kind of pause on that, because that's very interesting. That the active part of this, the nanofiber, the technology, stays in the interstitial space, and that reader just stays on board, right? It's there. You use it again and again.
That's right.
As opposed to throwing it away, right?
That's exactly right. And that itself, right? If you're not throwing electronics away, not only is it better for the environment, but that in itself brings the cost down, because the electronics are always the most important, most expensive.
But you're getting better data.
You're getting better. And you're getting better data.
So it's a win-win, yeah.
Yeah, you get continuous data, you get clinically validated data, so that physicians know what to do with it. And then you're actually doing in a way that, for the cost of a Netflix subscription, will make this technology available to people who actually need it. So, and listen, I don't want to get too much on the soapbox here. I mentioned earlier, I'm an immigrant. I come from a place where, or in an area of the world where it's much more cost sensitive. Listen, unfortunately, diseases are pretty much economic agnostic, right? If you're gonna develop diabetes, you're gonna develp diabetes, and if you're gonna develop cancer,
but hold on. I it may be agnostic in that sense, but look at diabetic foot ulcers, peripheral vascular disease, metabolic syndrome that are not well cared for. You often see that in an indigent patient population.
That's exactly what I mean, right? That's exactly what I mean. Whether you're rich or poor, whether you live in sub-Saharan Africa or Beverly Hills, you're going to develop diseases that medical technology could help you either manage or at least live better lives. Unfortunately, the access to this technology is often bifurcated on what you could actually afford to pay. And I come from an area, from Taiwan, et cetera, where CGMs are not available in national health insurance because the cost is just so high. So listen, we want this to be accessible to folks. I think it's not just good, it's a moral imperative. Our technology happens to actually be designed in that way where cost is not a barrier to adoption. But listen, from a business perspective, it's also good business, because it also means that we could help not just people in the US and Europe, we could actually help people around the world. And the number of folks who could benefit from our technology then becomes much, much greater. And we're looking forward to being able to do that because the cost burden is so much lower.
So I want to wrap it up, and I pardon the pun, but I want to shine a light on Profusa. The stock symbol is PFSA. I think that my feeling about this is that once people get to see what you're doing, it's going to be a hot commodity. I know that you had your IPO, and small stocks get beaten up all the time for a variety of reasons. But I think that you offer a tremendous opportunity to patients, to investors, to potential partners in the space. Maybe you can talk a little bit about what's coming next in terms of potential partnerships. Are you looking for things? What's looming in the future for Profusa?
Yeah, so now that we're a public company, I do have to actually make sure that we talk about it, not in specifics. But listen, I appreciate the team's effort and all the people that help us to actually get to this point. Now that we're a public company, I think we're really set up to be able to do fundamentally what we want to do, which is build the foundation of the company and commercialize the product and help as many people as we can with this transformational technology. And to do that, as we've done in the past, we live in a very robust village where folks like yourself and other companies and such are constantly interested in the development of this. And I think we're very open-minded in terms of how to accelerate our mission, our path to the mission, to be able to not have to reinvent the wheel if we don't have to, and get this technology out as quickly as we can to help as many people as possible. So without discussing specifics of what's happening next, I think our mentality has been and always will be that we'll take advantage of what's offered to us in this industry, in this ecosystem. And there are a lot of like-minded people like us to get things out there. And then secondly, listen, stock price is what it is. It's not something that I could control. I think ultimately, as people understand what Profusa is doing, and as we actually help folks, I think all of that will work itself out.
When was the first time we talked? Was it like 5 years ago, 10 years ago? I don't even remember, right?
It's got to be like 7-8 years ago, John.
And we talked about disrupting the disruptor, right? That was the line that I think that was memorable. And because that's what, in the world of exponential change, you got to look forward, but you got to look over your shoulder because things are changing very quickly. And the ability to disrupt the disruptor. For me, CGM is interesting. It was important, right? Pulse oximetry was important. It played a powerful tool, still does, and it always will. But there are other modalities that are coming very quickly. And that's, immediately I thought about Profusa. And boy, I mean, you gotta, blood levels are one thing. It's a mediocre surrogate marker that's often ambiguous and even confounding to clinical scenarios. Getting to the muscle, looking where the biochemistry happens, taking the analytics to where the chemistry occurs is so powerful. And that's always been what I've always loved about Profusa. It's a really interesting company. It's been I'm not going to say a long, hard road. It's been a road that's paved by science and paved by research. And your clinical data is so strong here that I think that's something you really have to leverage.
Yeah, no, thanks for that, John. Listen, I can't say that the journey has not been frustrating. It's rewarding for sure, but it's definitely had this dark periods where it's frustrating. And the frustration comes along from the fact that you want to move things along quicker and you want things to happen. You know under the hood what's going on, and you wish the regulators could see it as well and in real time. But I will say though, you're a father. I'm a parent of 3 wonderful kids, and I am grateful. Right, I am grateful that we live in a society where I don't have to worry about when our kids go to the doctor and the doctor wants to deploy some device on them, that it's not properly vetted and safe, et cetera. I just don't question it. And so as a parent, I appreciate it. As a technologist, it's frustrating. But I will say, though, that through the gauntlet, over the last 12, 13, 14 years, we are at a place now where it's really exciting for us to be able to bring this technology to the marketplace. And I think the next couple of years will be a lot of fun, and hopefully we can make an impact.
I think that that you've done your work, and I've looked at some of the other health tech devices, and a lot of them didn't do quite well because they really didn't have the science. They didn't have the clinical studies behind them to support the information. And I'm really, really excited about the nature of the clinical background that you have. And I think it's important for people to get to know Profusa. I think they have to start looking at what the heck is this new level? This is tissue levels, right?
Right.
And it's a powerful dynamic when you look at oxygen, when you look at glucose, you're looking at the metabolic parameters that are integral to life, integral to tumor growth or lack of tumor growth. It's just a powerful time. So I challenge all my friends, everybody out there, take a good look at Profusa, watch what's happening. The data is very, very compelling, and the company is poised to do great things with what they're doing now, with extension into new metabolic parameters, and with partnerships. So Ben, I'm going to wrap it up there. We went long. I think we could have talked another hour here.
Yeah, it's always fun talking to you, John.
But we're going to do it again, maybe next week or the week after, and try to dissect this a little bit, get into the nuances of interstitial blood oxygen and all that kind of stuff.
That'll be fun. Thanks a million. By the way, I see we have a comment here from the Liam Collins.
Yeah.
Kind of neat.
We had a comment, and they talked about the inert nature of some of these products, certain glass shattered, and how that was useful in finding something that's inert, like cataracts and contacts.
Right.
So, all right, Ben, I will talk to you soon. Everybody, keep an eye on Profusa. I think big things and important things that have critical clinical manifestations. Everybody, take care.